मी माझं शेअर स्क्रीन करून पाहते ना.
हो करणं. Everybody share your screen.
Good evening.
Can you see my screen?
Yes. Take it full screen.
Yes.
Yeah.
Full screen करून बघून घे आताच.
Okay.
Yes.
वैशाली तुला बघायचंय?
मीच फर्स्ट आहे. I'll just check.
Yeah.
Good evening, Alka ma'am.
हॅलो राजश्री, कशी आहेस?
Better.
आता उठली का कोविड मधनं? Why you are saying better? Not good?
Not good. Just somehow sitting for the chairing.
पफी लग रही है, पफी.
बहुत ही ज्यादा.
We will start क्या? Otherwise it will not. कांचन बघत राहशील सर्व.
हो मॅम, बघतच आहे. नाही चालत अजून जॉईन.
आपल्या लोकांना बऱ्यापैकी कळलंच नाही. किती वेळा तरी सांगितलं की याला लिंक.
हो, ते कळत नाहीये. रजिस्ट्रेशन केल्याशिवाय लिंक येणार नाही. ते थोडं
नाही, पण मी कित्येक वेळा तरी सांगितलं. लेट अस सी.
My sincere apologies for everybody waiting. Please accept your apologies.
Welcome, sir.
And the entire team over here. It's just that there are several parallel, meetings and sessions happening. So I just stepped out of the other one, which we just completed, and to get into another one, which we are going to bring in. Thank you so much, NOGS, for arranging this important meeting and training program for all the members of the society, the local society there. And hats off to you, Alka, for leading the way and making sure this program actually takes place today. And at a very short notice, you have been able to arrange all of this. And I can see almost 35 participants are there in today's meeting. I'm sure you and your team will plan for more such sessions.
Yes.
More and more members from your society can get oriented on this entire program.
Sir, many of our members couldn't get it, that they have to register like this, in spite of repeatedly telling them.
I'm sure.
And some people, they are saying they are not getting. So I and Joel are doing the things. I'm posting him the mail ID and he's posting me the links.
You know one thing very well. We people working in this profession are very poor readers and equally poor listeners. You know, I can't generalize that statement, but it is applicable to me. So maybe they have missed it, and I'm sure they'll join this at the next session after hearing from each one of you over here. Just to give you a background and to give you all a very warm welcome.
Sir, it will be after. Sir, excuse me. Our Master of Ceremony will invite you. Just
okay. Please, yeah.
Where is she? Kude geli? Manisha? Okay. I requested Shanta Kumari ma'am, but she couldn't join somehow.
No, she's on the flight right now.
Okay, sir.
Yeah.
So let me start. My Master of Ceremony, she might have lost her connection. So respected guest, Mr. Ajay Bharadwaj sir, all respected senior members and my dear friends. I'm indeed very happy to welcome you all for this respectful abortion care, a prestigious project of our Foxy President, Dr. Shanta Kumari. Our members who became master trainers are Dr. Vaishali Baradkar, Dr. Kanchan Dvedmuthe, Dr. Sangeeta Balkote, Dr. Seema Sathe, and Dr. Deepti Shende. As we all know, 15.6 million abortions that take place every year in India, and a significant proportion of them, they are unsafe. These unsafe abortions, they are the third largest cause of maternal mortality in our India. That leads to around 10 deaths for each day and thousands more facing morbidities. So it's time of an hour too that we should have an abortion care, which should be transformed from not just a medical procedure, but into a woman-centered, tender loving care approach by providing safe and legal abortion services. Taking into account different factors which the woman faces, like physical, mental health needs, and her personal circumstances, and the ability to assess the abortion services. We can convert the routine abortion care to women-centered care by giving them choice of options about the methods, the medical and the surgical, and the post-abortion contraception. We can make them the services accessible, quality care. All we have to do patiently, devoting time, maintaining their privacy and confidentiality. We have to use some recommended technologies like MVA and EVA and MMA, like terminologies. We have to adhere for the clinical standards and protocols for infection prevention, pain management, management of complications, and other clinical components of care. So here we are today because of vision of Dr. Shanta Madam. We are having this program totally based on making our women more and more safe by providing them an environment of mutual trust and confidence, so that they won't resort to unsafe method. We have with us today's guest, Dr. Ajay sir, who did initial brainstorming on this important social topic, social issue. Let me take an opportunity to formally introduce Mr. Ajay. Very down to earth, Mr. Ajay is a very polite Foxian I came across. Just I wanted to share my PPT presentation for Dr. Ajay, Mr. Ajay. Just a minute. I thought Shanta Madam will come, so I presented.
No, she would have definitely joined. It's just
Yes.
that she's on the flight right now. I met her in the afternoon and
Yes.
on her way to the airport. So yeah.
Yes, yes. So Dr. Ajay, Mr. Ajay is very down to earth personality, very polite. You can say one of us Foxian I came across. He is the founder member of Avni Health Foundation and NGO. And this AV and NI are based on his daughter's name, I believe. Isn't it, sir? Yeah. So मेरा homework अच्छा है, sir.
Very good homework. Yeah.
His 31-year-long professional career has focused on pursuing his life goals and span contributions in the business sector, corporate management, marketing and sales, as well as in the public health and development sectors impacting on the society at large. A very strong professional providing leadership. We have seen strategic direction. We have seen program implementation. Sir के जैसा कोई कर ही नहीं सकता. Management and monitoring, support to several national flagships at a single time. Isn't it, sir? अभी आप वहां से करके अभी आए, अभी इसके बाद में कोई और प्रोग्राम में जाने वाले. He has worked across 21 states of India and internationally in Nigeria, South Africa, and Bangladesh. He works closely at the highest level of government, providing technical expertise in ministerial, secretarial level, and WHO, WDF, IDA, MUHS, SOGON, OGSB in association with Sparkman Center for Global Health, School of Public Health, and University of Alabama at Birmingham, and School of Public Health, Vanderbilt University. A very strong team player. We have seen him conducting the DIRA sessions as well as RAC session. So welcome, sir. Welcome. And we welcome you for your introductory words for our program, sir.
Yeah, thank you so much, Malka, and the entire team for organizing this, as I said earlier, at a very, very short notice, and taking the lead in the Vidarbha region just before the summer sets in and one starts relishing all the lovely oranges out there. Yeah. Having said that, having worked with each one of you at some point or the other, and several others who are in the medical profession, not just associated with Foxy, it's interesting that I have been given the honorary degree without any certification, without any documentation of being a doctor. So yes, a lot of times it gets confusing. I also don't stop them from calling me doctor, because it always feels good to be called a doctor, even though you're not a doctor. But yeah, that's how life goes, and one needs to go on. Coming back to the RAC program itself, RAC is Respectful Abortion Care, and it's initiative which has been started by our beloved President, Dr. Shanta Kumari, in close collaboration and funding from the WHO India office. WHO India office, along with Government of India and few technical experts, has been responsible for bringing about this mandated change in the MTP amendment, which came about as recently in September 2021. We'll hear about that a little more when we come to the presentation. But strong advocacy efforts by all the partners, including, importantly, WHO, both the India office and the regional office, that these amendments have come about in the approach for Government of India, Ministry of Health. Now, it's interesting to see that how things have transformed and changed over the years. In the 70s, India was amongst the handful of countries which had something which was supporting and rules and regulations related to abortion. And we have come a long way in that, and many countries even today are struggling to get something like this in their respective countries. So 70s was the era when it was called the unsafe abortion and rules related to it, which changed in 2002, something known as, safe abortion. And now here we are in 2020, 50 years later, to call it a respectful abortion care, the rightful way to call this entire initiative to move forward. And the onus will be on each one of us sitting here in the program today to take this respectful abortion care in the right earnest and forward for the women of our country and for the respective practices that we have in the spheres that we are working in the cities, towns, and states that we are working in. We need to see how we can continue adding to the dialogue of reduction of maternal mortality, or MMR, in our country. It has gone down substantially from 500 plus at one point in time to about 100 plus right now. Several states, especially the southern states, have really made a big difference and are nearing less than 100 or less than 50. Maharashtra specifically has also done major steps and has achieved quite a bit number. Maharashtra, Karnataka, Tamil Nadu are the immediate number 2, number 3 states which have made a difference as far as reduction in maternal mortality is concerned. Principal causes or the things that have led to about this kind of reduction essentially has been on provision of emergency obstetric care where it is needed the most. And 2 is providing viable options for abortion care and abortion, including the contraception availability, a wide range or a basket of contraceptive availability through the public health system, which has contributed to where we are today. And India has been recognized for the achievements as far as the MDGs were concerned earlier, and now the SDGs which are concerned going forward. So I think it's been good, excellent work done by each and every one of you in your respective areas, which have kind of contributed to where we are today and taking the whole process forward. With that, I hand over back to Alka and the team to take us through this entire process, and all the very best. We look forward to your continued support and value in taking this forward. It's good to see you, Lakshmi. You have something to add?
Yeah. I just wanted to welcome you, Ajay, to Nagpur, and I want to appreciate Dr. Alka, who has organized this program at such a short notice. And you can always count on Nagpur Obstetric Gynec Society for all your training programs, RAC as well as WOW.
Thank you so much.
So, thank you, Ajay. And Alka, hats off to you.
Thank you. Over to you, Manishi.
Thank you. Thank you, Alka ma'am. Thank you, Alka ma'am, Ajay sir. It is a great evening today, and Foxy in association with Nagpur Obstetric and Gynecological Society invite you for respectful respectful abortion care training today. We start off with the first session, that is medical termination of pregnancy termination amendment 2021, laws, rules and implications for providers. The esteemed chairpersons for this session are Dr. Vaidehi Marathe, Dr. Varsha Dhaule ma'am, Dr. Rajzi Sengupta. This talk is going to be delivered by Dr. Vaishali Varadkar, who is a senior consultant gynecologist and laparoscopic surgeon, a fellow guide of ICMCH since 2011, a clinical mentor and master trainer for comprehensive abortion care by IPAS India for past many years. Welcome, ma'am, and you can deliver your talk.
Yeah, thank you, Manisha. Thank you so much for the kind words. I'll share my screen. Just a minute. Yeah.
Yeah. Especially you can.
It's a slideshow on karat hai. Okay. Is it visible now?
Yes.
Okay. Very good evening to all of you. At the outset, I would like to
Slideshow nahi hai.
Slideshow नाही झालाय ma'am.
slideshow. Is it okay now?
Yes.
Yes.
Yeah. Okay. A very good evening to all of you. At the outset, I would like to thank Alka ma'am for giving me this opportunity. She has been a wonderful president all through. And I would also like to acknowledge the presence of Ajay sir. He's been always behind us for all these activities and projects of Foxy. So today we have all joined for a very important topic, respectful abortion care. And due to the recent amendment, we are discussing about it. So as we all know that MTP is a very minor and simple procedure. But due to the legality involved in it, we as gynecologists and service provider should know, be updated and should know what the law says about it. So in the next 15 to 20 minutes, what we are going to know about it, what the new law says and what are the changes in the rules. That is the amendments what have been going around since 2021. But before going through the amendments, we will have a look at the statistics. What Alka ma'am had previously said almost all throughout the year in India, 15.6 million abortions are being conducted. And out of these, more than 50%, almost maybe 60% are unsafe abortions. And 8% of the maternal deaths are due to these unsafe abortions, it being the third leading cause of maternal mortality in India. And almost half of the pregnancy related deaths in women are in those who are less than 24 years of age. So we should, it is quite alarming and we should realize that this is preventable. What according to the WHO, when we say that the abortion, when can we say that the abortion is safe? When these two criteria are fulfilled, that is by appropriate methods or the MTP is conducted by a trained person. WHO defines unsafe abortions as termination of pregnancy on an either by a person lacking the necessary skills or in an environment lacking the minimum medical standards or both. So if either of the criteria is not being fulfilled, we have to call that abortion as unsafe. When we are talking about the this amendment, which is giving importance to safe and comprehensive care as mandated by law, we will just go through this law in India, abortions were legalized in 1971 and with time to time amendments. The recent MTP amendment bill was passed by the Lok Sabha on 17th March 2020, and it took almost 1 year for the Rajya Sabha to pass it on 17th March 2021, and it received the assent of President on 25th March. And according to the official gazette, it has been implemented and has come into force from 24th September 2021. So now going through what the module, the aim of our module is to know about the various amendments in this law. The first one is a modification in the requirement of the provider. We are the providers. So what the law say previously, I will just one by one go through what the previous act used to say. In the previous act, only the opinion of one person, one registered medical practitioner was required till 12 weeks. And for the abortions, that is terminations between 12 to 20 weeks, the opinion of 2 medical practitioners, that is RMP, what we call registered medical practitioner, was required. But now, according to the amendment, only one registered medical practitioner can give his opinion till 20 weeks of pregnancy. And then if we are terminating it in between 20 to 24 weeks, then only the opinion of 2 registered medical practitioners is required. We should know how it will help. It will increase the number of terminations being held at facilities like PHC, where usually there is only one doctor, so they can terminate it till 20 weeks. Next point is modification in the for vulnerable group of women. Previously, it was said that MTP is permissible beyond 20 weeks only if it is really necessary to save the life of the pregnant woman. But now the new amendment has enhanced the upper gestational limit from 20 to 24 weeks, and further enhancement, and especially in cases of birth defects which are not which will be detrimental for the life of the fetus and the newborn baby. In those cases, there has been no limit, upper age limit for gestational age limit for the for conducting a termination. In that case, as we will further discuss, opinion of the medical board is to be taken. Here also, this will increase the access of women to safe and legal abortion in cases where the victims are minors or they are victims of violence like rape. Then modification in the marital status is also very important. With the changing social conditions in the country, previously the indication for failure of contraceptive for terminating a pregnancy was only applicable in for married women or her husband. But now this has been scraped off, and irrespective of her marital status, the women who have conceived and want termination can go for legal abortion. So this is again a very important step, increasing the access to safe and legal abortion for any women irrespective of her marital status. And this is also important since there is increase in the legal age of marriage. Then this is also one of the important point in this amendment, that the name and other particulars of a woman who has opted for termination shall not be revealed to anyone other than any authority who has been authorized by law for the time being, like maybe her employee or someone. So the privacy and confidentiality is maintained. These are the 2 important features of this amendment: confidentiality and privacy, and safety is also very important. So the rules under the MTP Amendment Act specifically give stress to define special or vulnerable category of women eligible for extended gestational age period for termination of pregnancy from 20 to 24 weeks. Then the norms of registered medical practitioner whose opinion is required, they have defined them at different gestational age, as we will discuss further. And then the formation of medical board, which is important for termination beyond 24 weeks. That is also we'll discuss further. So first we'll have discuss about the special category of women eligible for MTP between 20 to 24 weeks. Here, those who are victims of sexual assault, rape, they are considered. Then women with pregnancy in some humanitarian settings, disaster or emergency situations, they can undergo termination. Then if during the ongoing pregnancy there is change in the marital status of the woman, like she gets divorced or becomes a widow, then in that condition, if she opts for termination, she is she may get terminated. Anybody should be willing to get her termination done. Then women with physical disabilities, then mentally ill women, including those with mental retardation, then minors, and then again fetal anomalies which have a substantial risk to the life of the child. In such cases, these are considered as special category of women, vulnerable women who are eligible for MTP between 20 to 24 weeks, which previously was only till 20 weeks. So, and again, the norms for registered medical practitioners have changed. Medical practice, like RMP, that is registered medical practitioner, is defined as a person who holds an MBBS degree plus who has assisted in 25 cases of MTP, of which at least 5 were done independently. Then a person who is holding MBBS degree and has a 6 months of house surgency in obs and gynae. Then medical practice, a person who has MBBS plus a postgraduate degree or diploma in OBGY, or a person who has MBBS degree plus has an experience of at least 1 year of practice in OBGY. Here again, the stress is that opinion of only one person is required up to 20 weeks. Beyond 20 weeks till 24 weeks, opinion of 2 RMP. And beyond that, that is beyond 24 weeks, medical board has to give the opinion. Then this is an amendment in the what I told you, that was the previous norms for RMP. This is an amendment. Additional category of RMP has been added to the previous 4 because these days medical abortions are being medical methods of abortion are practiced quite often. So for termination up to 9 weeks, where medical methods are being used, an RMP with experience in the practice of OBGY at any hospital for 3 months and training with training with performance of 10 cases of MTP by medical methods under a supervision of a RMP in a hospital, which is a training institute which approved for this purpose by the government. Then the norms for RMP are different for different gestational age. So first I'll discuss for those with till 12 weeks where medical methods can be practiced. Here all the 5 categories of RMP, that is those who have an experience of only 3 months in the practice of OBGY and have performed at least 10 cases by medical methods of abortion, medical methods under the supervision of an RMP in a hospital approved by the government. Then the previous 4, which was they have assisted a RMP in the performance of at least 25 cases, where 5 cases were performed independently, then holding a postgraduate diploma or degree in OBGY or a 6 months house surgency in OBGY, or they are practicing for at least 1 year in OBGY. All these 5 are eligible for doing termination till 9 weeks. Then further, if the termination is between till 12 weeks, then the first one, those who have only an experience of working for 10 cases of medical methods of abortion, they cannot do for 12 weeks. So the rest of the 4, they are having eligibility to perform termination beyond 9 to 12 weeks, beyond 9 weeks. Then for terminations beyond 12 weeks, but till 20 weeks, that is what we used to do, second trimester MTPs. In the first one, those who are having experience of assisting in 25 cases, they are removed, and the rest of the 3, they can do termination till 20 weeks. Then beyond 20 to till 24 weeks, that is what has been added in this amendment. The rest of the 3, that is those who hold a postgraduate degree or diploma in OBGY, or those who have any practice, who have completed 6 months of house surgery in OBGY, or have at least worked for 1 year in OBGY, they are eligible to do till 24 weeks. And then when we talk about in this, there will be opinion of 2 registered here till 24 weeks. It will be opinion of 2 registered medical practitioner will be required. But if we are considering beyond 24 weeks, then a medical opinion of a medical board is required for the termination procedure. And when the medical board approves that the termination can be carried out, then this termination can be carried out by a practitioner who holds a degree of postgraduate or diploma in OBGY, or a person who has an experience of working in OBGY for at least 1 year. And this has to be done while taking all due safety precautions and after appropriate counseling. So when we are talking of the medical board, who can be the members of the medical board? A gynecologist, a pediatrician, or a radiologist or sonologist. Then the powers of the medical board are to allow or deny termination of pregnancy beyond 20. They have the right to whether allow or deny. So they consider what are the indications and would it be safe for the women at that particular gestational age, and the congenital malformation, is it really having a substantial risk which will be incompatible with life? So after considering all this, they have the right to allow or deny termination of pregnancy. Then they can add other specialists to their team, or they can ask for any further investigations. In this, I would like to specially mention that FOXI, our FOXI president, with the ministry guidance and WHO support, can opt and host medical board information on the website. So then coming to the functions of the medical board, what they do, first they have to examine the woman and her reports, who would approach for when that woman has approached for termination. So, and then they give their opinion in form D with regards to the termination. And if they are rejecting, the rejection should be given within 3 days of receiving the request. But if they have approved for termination, then the termination should be carried out within 5 days of receipt of the request, after appropriate counseling and with all due safety precautions. So here again, FOXI has an important role to play in ensuring that the board functions in every state as is stated in this amendment. So I would like to conclude by saying that the new law will contribute towards ending preventable maternal mortality and to help meet the sustainable development goals pertaining to reducing the mortality and to universal access to sexual and reproductive health and rights. The amendments will increase the ambit and access of women to safe abortion services and will ensure dignity, autonomy, confidentiality, and justice for women who need to terminate pregnancy. Thank you.
So are we supposed to conclude?
Thank you, Vaishali ma'am. Ma'am, the chairpersons can give their valuable inputs. Vaidehi ma'am.
Yeah. So, Vaishali, congratulations for this very beautiful and very crystal clear presentation. Definitely, these amendments will help provide universal access to reproductive healthcare services to all the women. And these amendments also, I'm sure, will definitely address many of the challenges that we face and the millions of women in India face while they have to undergo abortions. So, I think that's the message today. So, congratulations, Vaishali, once again for this very lucid presentation.
Thank you so much. Thank you.
Thank you, Vaidehi ma'am.
I would like to say something.
Yes, ma'am.
Alka, just few comments.
Yes, yes.
Yeah. At the outset, Vaishali, congratulations, presented very well. It is almost 50 years that we are now into respectful abortion care for the women. It took almost 50 years from 1971 to now. And the greatest amendment which has been beneficial is for the unmarried women, right? Unmarried women were kahin pe bhi wo ja nahi sakte the. So this is the greatest amendment that yes, they can even use failure of contraception and other indications and they can go ahead with the MTPs. Thirdly, what I want is Foxy should, jaise abhi Foxy has taken an initiative into respectful abortion care. What I want is Foxy should also take part into the functioning of everything, right? Because now, after the RV episode, I am getting a lot of calls that people are coming and examining and asking what is not there in Form 1, what is not there in Form 3, and so there's so much of harassment is going on to the doctors. What I want to say is when we all know that threatened abortions and missed abortions and all this are not taken as considered as MTPs, they are still asking that what comes into the other. That is abortions, you give one, a number of abortions which you're doing, and you also give a number of threatened abortions and missed abortions and incomplete. So why this should happen? This shouldn't happen. Foxy should take a stand saying that when it is abortion, it is medical termination of pregnancy, it is a live pregnancy, either by medical methods or by surgical methods, only that has to be taken. Secondly, everybody is pestering for issue-wise breakup. When we had a 14-column Form 3, nothing regarding issue breakup was there, only the patient's name and why she is given the MTP and on what ground she is being permitted the MTP. Now also you have increased 2 more columns, you have made it a 16-column register. You have increased the post-abortion care, the remarks and they say remain the same. But the issue-wise breakup is not there. That yes, that's this female has already 1 female or 2 female or 1 child or 2 child or 3 children. And that is why she is opting for. So something regarding this also has to be taken. And this is a word that whenever the amendments are coming, the amendments as they are easy for the patients, they should be much more easier for the gynecologist, also much more safer for us. We are ready to give this much of care to the patients, but not at the cost of your own harassment, right? So Alka, this is what I wanted to convey through this. I think Ajay sir is there and maybe listening. So probably we can have some connection, but this is one thing which I have marked that yes, we need to go a step ahead and do some amendments in this. Right?
Yes.
That's all I wanted to say. Rest it was a good talk.
Yeah.
Thanks.
Rajeshri, do you
Thank
want
you.
to comment?
Yes, definitely. Thank you. Vaishali ma'am, it was as usual a very nice talk. I won't be speaking much. I just had a few concerns regarding these amendments. Just on the lines of what Varsha madam has already clarified that it should be obstetrician friendly. Now that we are having going to have one person allowed to one RMP allowed to prescribe till 20 weeks. We don't want to at apex centers, we don't want to face more spoiled cases and more delayed cases and complicated cases, because that will defeat the whole purpose of making abortion safe for women. So starting from early gestation itself, we need to see to it, and when at Foxy level, we need to see to it that medical boards are in place and we have doctors in place who can prescribe, rule out ectopics, prescribe pills properly, safely, and refer patients in good time. I think we all have to work in unison to make these amendments really wholesome and safe for our doctors as well as for our patients. Thank you so much.
Very well said. Over to you, Manisha.
Thank you, Vaishali ma'am and esteemed chairpersons for the valuable inputs. We go on to the next session, which is safe abortion, updates in technology, availability, Quality of Medicines and Methods Available by Dr. Kanchan Dwimote. The esteemed chairpersons are Dr. Sushma Deshmukh ma'am, Dr. Pragati Khalatkar, and Dr. Sumit Beheti. Dr. Kanchan Dwimote is an associate professor in KP SIMS, RC and LMH Nagpur. She is also an ALSO, BLSO, BLS instructor. I welcome you, ma'am.
Thank you. So I'll share my screen. Can you see?
Yes, ma'am.
Good afternoon, friends. So first of all, I thank Dr. Alka ma'am for making me the part of this visionary project of FOXY. So we'll start with this module. In this module, we'll cover the updates in technology. So as such, there are no updates in technology of abortions after medical methods of abortion. We'll see brief this. These are the main points in this session. So existing guidelines about abortions. Then we'll see for the pre-abortion assessment, then medical methods of abortion and surgical methods of abortion. So these are the guidelines, WHO guidelines about the abortions. This is a roadmap to WHO safe abortions guideline. The first guidelines were given in the 2012, that is a technical and policy guidelines for health system. Then in 2014, there is a handbook for safe abortion. In 2015, there is a health worker role in providing safe abortion care and post-abortion contraceptions guidelines. In 2018, there is a medical method of abortion guidelines. And recently in 2019, we have a guidelines on self-care intervention for health. Ministry of Family Health and Family Welfare. These are the national guidelines for the abortions. First MTP Act came into existence in 1971 and it is enforced worldwide, nationwide in 1972. Since then, there is no change until there is historic change that occurs in 2021 when the Medical Termination of Pregnancy Amendment Act 2021 came. And this act mandates comprehensive care by this law. The law was changed on 25th March 2021 and rules changed on 24th September 2021. All guidelines have 3 key areas of abortion safely. These 3 key areas are pre-abortion care, then abortion care methods, and aftercare and follow-up, including post-abortion contraception and counseling. So what are the steps in decision making? Whenever patients comes to you, first thing is we will take her medical history. Then we'll go for physical examination, which will include general examination, pelvic examination, abdominal examination. And if necessary and available, we'll advise her some laboratory investigation. Then we'll discuss the contraception with the patients. We'll give her options about the availability of the methods for termination of pregnancy. If the woman chooses to have an abortion, she should be allowed to choose from among the available methods that are appropriate for her based on the duration of pregnancy and her medical condition. Now we'll see about the pre-abortion assessment and counseling. So these are the components of the pre-abortion assessment. Whenever the woman seeking first abortions, first trimester abortion came to you, there are the 4 things we have to do. First is the detailed history taking. Second is general, physical and pelvic examination. Then advice, laboratory and other investigations which are relevant to her. And then we have to give her information about the process, types of abortion, availability of abortions, and counseling about the contraception. It is very important. We have to counsel her about the contraception after abortion. This is a gestational age determination by the examination. So this when at the 4 weeks, this is a pregnancy dating by physical examination. Physical examination includes bimanual pelvic and abdominal examination. After 4 weeks of gestation, the uterus size increased by 1 centimeter per week. At up to 12 weeks, the uterus is pelvic organ. After 12 weeks of gestation, the uterus rise out of the pelvis. After 15 to 16 weeks of gestation, the uterus reaches the midpoint between the symphysis pubis and the umbilicus. At 20 weeks, the uterus reaches the umbilicus. And after 20 weeks of gestation, the fundal height in centimeter required measured from the symphysis pubis approximates the weeks of gestation. There are some limitations to dating by uterine size on physical examination in conditions such as if patient is having uterine malformations or fibroid, if she is having multiple gestation, if there is a marked uterine retroversion, if patient is obese, or if she is having the molar pregnancy. In these patients, this method may not be accurate for the dating of the pregnancy. A uterus that is smaller than expected may indicate that the woman is not pregnant. She may have inaccurate menstrual dating, or there may be ectopic pregnancy or abnormal intrauterine pregnancy, such as spontaneous or misabortion. If the uterus is larger than the expected, it may indicate that there may be inaccurate menstrual dating, multiple pregnancy, uterine anomalies such as fibroids, or molar pregnancy. Pre-abortion investigations. So remember that routine lab tests are not prerequisite for abortion services. Tests that may be performed as per the individual risk factor on finding of physical examination. Pregnancy test, if pregnancy is unconfirmed still. Hemoglobin or hematocrit for suspected anemia. Research testing where Rh immunoglobulin is available for the Rh negative woman. HIV counseling and testing. STI screening usually performed during the pelvic examination, and other laboratory tests such as KFT, LFT if required by her medical history. Remember, ultrasound is not necessary unless the diagnosis of pregnancy is not certain, or if we are suspecting ectopic pregnancy or misabortion. So ultrasound is not necessary before abortion according to guidelines. Pre-abortion counseling include the 3 things. We have to ask, inform something, and then document. So we have to ask the patient or woman about the thoughts about terminating the pregnancy, and we have to ask her reason for termination of pregnancy. We have to write that reason in our form, MTP form. We have to inform her certain things, inform that early abortion is safe, counsel her about the importance of trained provider performing the procedure for safety, so that she should not go to some dai or some quack, and she should come for to RMP for the abortion. We have to explain her about the available methods of abortion, explain her risk and warning signs associated with the abortion method, counsel her about the contraception, stress her that she can get pregnant as soon as 14 days after the abortion. So she should use some contraception after abortion. Advise her about the resumption of her normal activities, when she can resume her activities, including the sexual intercourse, and explain and advise about any other follow-up care. We have to document certain things. We have to document her informed written consent and her decision to accept post-abortion contraception, whether she is willing for IUCD or sterilization or any other method of contraception, that has to be documented. Even if she is not willing for contraception, she will be provided with the abortion services. Am I audible?
Yes, ma'am.
Yes, you are audible.
Yes. So in clinical management of abortion, what are the global guidelines? According to global guidelines, abortion, if the pregnancy is less than 12 weeks, global recommendation is about mifepristone and misoprostol, or misoprostol only, or vacuum aspiration. If the pregnancy is more than 12 weeks, mifepristone and misoprostol only, and dilatation and evacuation. Not recommended is the dilatation and sharp curettage, that is DNC is not recommended for the abortion. But Government of India recommends medical until 9 weeks only. Though globally we are doing less than 12 weeks, but Government of India recommends only for 9 weeks medical method of abortion. If the pregnancy is up to 7 weeks, that is 49 days, we have to give mifepristone 200 mg oral, wait for 24 to 48 hours, and then misoprostol 800 microgram sublingual, buccal, vaginal, or oral. If it is 7 to 9 weeks, that is 49 to 63 days, then give mifepristone 200 mg oral, wait for 24 to 48 hours, and then give misoprostol 800 microgram sublingual, buccal, vaginal. And only difference is we cannot give buccal misoprostol in pregnancy, which is 7 to 9 weeks. That is a difference between termination of pregnancy, MMA of 7 weeks and 7 to 9 weeks. Methods of first trimester abortion, we have medical method and surgical methods. So mifepristone and misoprostol tablets are used for medical method of abortion. Mifepristone is an antiprogesterone. It inhibits the action of progesterone. It interferes with the continuation of pregnancy as it is an antiprogesterone. Initial oral dose of mifepristone followed by misoprostol. Misoprostol is a prostaglandin E1 analog. Misoprostol causes cervical softening, uterine contraction, and expulsion of product of conception. The protocol of mifepristone and misoprostol. On day 1, we'll give the mifepristone. It is 200 mg of mifepristone oral. And if patient is Rh negative, we have to give anti-D 50 microgram on the day 1 only when we give her mifepristone. On day 3, it is a misoprostol. It is a spelling mistake. It is a misoprostol administration. So up to 7 weeks, we can give 400 microgram misoprostol, 2 tablets of 200 microgram each, sublingual, buccal, vaginal, or oral. Or if it is a 7 to 9 weeks, then 800 microgram sublingual, buccal, vaginal, and not oral. In addition, we can give some analgesic, that is ibuprofen, antiemetics if patient is complaining of nausea, vomiting, and offers contraception, that is very, very necessary. Follow-up visit is within day 15 or on the day 15. What has to done on the follow-up visit? We have to confirm and ensure the completeness of procedure and offers contraception if not already done so. We will have a separate topic on the post-abortion contraception. We'll see what are the contraceptions which can be used after abortions. Now, these are the characteristics of different routes of misoprostol administration for first trimester abortion. Oral route, the pills are swallowed. It is recommended up to 7 weeks, that is 49 days for first trimester abortion. Side effect includes diarrhea, nausea, fever, and chills. Buccal route, pills are placed between the gums and the cheek and swallowed after 30 minutes. Side effects are more fever and chills than with the vaginal route. Sublingual, the pills are placed under the tongue and swallowed after 30 minutes. There is an increased fever, chills, diarrhea, and vomiting compared to the vaginal route, but it is the fastest onset of action as the highest plasma concentration levels. Vaginal, the pills are placed in the vaginal fornices, deep portion of the vagina, and woman is instructed to lie down for 30 minutes. Pills fragment may be visible by vaginal administration, and it has the lowest rate of side effect with vaginal. So with sublingual, we have the fastest onset of action, but with vaginal, it has a lowest rate of side effect. This is a placement of tablet in buccal and sublingual. In sublingual, we have to keep below the tongue. Now, this is a WHO drug regime recommended for abortion. So WHO recommend medical method for less than 12 weeks, and in India, it is recommended for less than 9 weeks only. The WHO regime is mifepristone and misoprostol. So mifepristone 200 mg per oral once. After 1 to 2 days, we'll give misoprostol 800 microgram buccal per vaginal or sublingual. And there may be a misoprostol only regimen, that is misoprostol 800 microgram buccal per vaginal or sublingual. Vaginal bleeding for 2 weeks is normal after medical abortion. Such bleeding can last up to the 45 days in rare cases. So for 15 days, if patient is complaining of bleeding after medical method, it is a normal and we don't have to worry for that. So provision of MMA services. The services should be available at the primary care level with referral system in place for all required higher level care. Additional services may be provided to individuals seeking medical abortion. So we have to provide these services additionally if patient is coming for abortion. So it includes the counseling and testing for sexually transmitted diseases, then abuse support services, psychological or social services, or other specialist health or medical services. We have to give the iron tablets for anemia if needed, provide any necessary pain medication, and provide the emotional support if needed to the patient. In follow-up care, routine follow-up is not necessary following an uncomplicated medical abortion using mifepristone and misoprostol. A follow-up visit 7 to 14 days after the procedure may be offered to provide contraceptive counseling and services, emotional support, or address any medical concern. A routine follow-up visit is recommended only in case of medical abortion using misoprostol alone or to assess the success of abortion. So after medical method, routine follow-up is not necessary unless you are using the misoprostol only regime, but we can ask her for follow-up for the contraceptive counseling or to assess the completion of the process. In follow-up care, the woman's assess the woman's recovery and ask for any signs or symptoms of ongoing pregnancy, review any medical records and referral documents, ask about any symptoms experienced since the procedure, whether she's complaining of anything, pain in abdomen or heavy bleeding, we have to ask her. Perform a focused physical examination for any complaint, assess the woman's fertility goal and need for contraceptive services if not provided earlier. We have to stress on the contraception in follow-up care. To summarize the medical method of abortion, on day 1, what to do? We have to do physical and pelvic examination, confirm eligibility, that is up to 49 days or 7 weeks of LMP, tablet mifepristone 200 mg orally, offer anti-D 50 microgram to Rh negative woman. Tell the woman that return for misoprostol administration after 2 days. Contact address and phone number of the facility or center where she can go in case of emergency, that should be written on her OPD paper, and record her experience of any side effect on the MMA card. 3% women may expel completely with mifepristone alone, but misoprostol schedule should be completed. Second visit, that is on day 3, give misoprostol 400 micrograms sublingual, buccal, vaginal or oral. Observe for 4 hours. Then if required, give analgesic ibuprofen 400 mg. Contraceptive options, condom, hormonal methods, oral or injectable should be explained to the patient. Tell the woman that mean period of bleeding is 8 to 13 days. Possible side effect may be there such as nausea, vomiting, diarrhea, headache, fever or dizziness. Report in case of excessive bleeding, pain in abdomen or fever. Report if there is no bleeding 24 hours after misoprostol. Consider giving the additional dose of misoprostol. 75% of women abort within the 4 to 6 hours after the misoprostol administration. Follow-up visit on the day 15. We have to do pelvic examination to ensure the completion of abortion. Give her contraceptive options. Tell the woman that there is immediate return of fertility. So after 13 days or after 10 to 13 days, there will be a return of fertility after the abortion. She has to use the contraception after these days. Report back if there are no periods within 6 weeks of completion of the abortion process. USG only if examination does not confirm the completion of procedure. If you are suspecting that the abortion is not complete, there is incomplete abortion, then only advise the USG. What are the side effects and complications of this medical method? So patient may be complaining of pain. We should be respectful about that complaint. If patient is complaining the pain, there should be non-judgmental communication. We should give her verbal support, adequate counseling about the pain. Before procedure also, we have to counsel her that there may be a pain. Then there should be a support person with the patient. Give analgesic ibuprofen 400 mg. If there is a persistent pain with failure to respond to these drugs for several hours, warrants evaluation for other causes such as ectopic pregnancy, infection or incomplete abortion. Patient may be complaining of nausea, vomiting. We have to reassure her that it is a self-limiting and it will recover with time. There may be a diarrhea. Again, it is we have to reassure the patient that it is a self-limiting. An infection that should be confirmed by physical examination, and if there is evidence of infection, we have to start the antibiotic. This is an action for failure or continuation of the after the medical abortion. So failure of the medical method of abortion, offer vacuum aspiration or repeat the medical method. If there is incomplete result of MMA, observe unless the heavy bleeding is there. So if bleeding resolves, uterus is normal size, the abortion is complete. If heavy bleeding continue, we'll see the protocol for heavy bleeding in next slide. Or we can repeat the misoprostol if there is an incomplete abortion, or we can offer surgical method of evacuation. If the patient has a excessive bleeding PV, so when we'll call it as a excessive bleeding PV, so if bleeding is more than her menstrual cycle, or she is soaking 2 pads in 1 hour or for 2 consecutive hours. So 2 pad in 1 hour for 2 consecutive hours, it is known as a heavy bleeding. So bleeding, if bleeding decreases over time, we have to give her routine care, keep a watch on her vitals and bleeding PV, and she can go home. If bleeding is if woman is stable and bleeding reduces, then observe and monitor vital signs and bleeding per vaginal for more than 1 hour. If bleeding continues, am I audible?
Yes, ma'am.
Yeah.
Yes, ma'am, you're audible.
If in spite of this bleeding continues, we have to do her USG. If USG suggestive of minimum decidual beats, we have to wait and watch. If there are POCs and decidual beats, but woman is stable, we can go for misoprostol 600 microgram oral or 400 microgram sublingual. If woman is not stable, go for vacuum aspiration. If there is a continuation of pregnancy, USG is suggestive of the sac in the uterus, we have to go for vacuum aspiration. Since the MMA comes under the purview of MTP Acts, the documentation is similar to that required for the vacuum aspiration procedure. It is mandatory to fill the following form, that is Form C is consent form. Form 1 is the RMP opinion. Form 2 is monthly reporting form to be sent to district authority. And Form 3 is admission register for case record. So the form which we are using for suction evacuation, that is this surgical abortion, same forms are for medical method of abortions. Now we'll see the different methods of first trimester abortion. Surgical, we have seen the medical method, and next is the surgical method of abortion. So vacuum aspiration is the recommended technique of surgical abortion for pregnancies up to 12 weeks only. WHO recommends manual vacuum aspiration as the safest method. The procedure should not be routinely completed by sharp curettage. So we should not do curettage after the MVA. Vacuum aspiration by the MVA, it is a procedure of abortion performed is same regardless of the type of vacuum used. So it may be manual vacuum aspiration or electric aspiration. So this MVA syringe, it is a handheld aspirator used to generate the vacuum. Aspirator is attached to the cannula 4 to 12 mm in diameter. There are different types of cannulas available from 4 to 12 mm in diameter. Cannula can be used in multiple settings, including those with electricity. So even if we are doing the this electric aspiration, this cannula can be used for that. IPAS or easy grip cannula size corresponds with the week of gestation. So the 8 mm cannula for 8 weeks gestation and 10 mm for the 10-week gestation. So cannula size is corresponding to the weeks of gestation. Electric vacuum aspiration, an electric pump is used to generate the vacuum, and it can accommodate cannula of manual vacuum aspiration with the correct size tubing. Cervical priming. It is may be considered for women with a pregnancy of any gestational age to prepare the cervix and make it soft and easy to dilate. Recommended method for cervical preparation before the surgical abortion in first trimester are oral mifepristone 200 mg 24 to 48 hours in advance, or misoprostol 400 microgram administered sublingually 2 to 3 hours prior to the procedure, or misoprostol 400 microgram administered vaginally 3 hours prior to the procedure, or laminateria tent placed intracervically 6 to 24 hours prior to the procedure if prostaglandins are contraindicated in some patients, so we can use this laminate area. Pain management plan, important. It is an important component of quality abortion care. It reduces the pain and anxiety and makes the woman comfortable. There are two components of pain management, non-pharmacological and pharmacological. In non-pharmacological management, it includes the psychological support to the patient, explain each step to the woman in advance, perform the procedure gently and smoothly, and encourage the woman to relax and breathe. Then pharmacological pain management. So source of pain and its management. So first is if patient is anxious, so we will give some anxiolytic, that is diazepam. Diazepam 10 mg orally 1 hour prior to procedure, or 2 to 5 mg IV 20 minutes prior to the procedure. Duration of effect is 4 to 6 hours, and side effect may be disorientation or dizziness. And we can also give a general anesthesia to the patient for the surgical abortion. If the pain is due to the cervical dilatation, we can use the lignocaine or local anesthesia, 10 ml of the 1% lignocaine for paracervical block. Duration of effect is 60 to 90 minutes, and patient may complain of dizziness and seizures. We can give analgesic NSAIDs such as ibuprofen, 400 to 800 milligram, 1 hour prior to the procedure. Duration of effect is 4 to 6 hours, and the side effect may be gastritis. If patient has a uterine cramping after the procedure, give the analgesic ibuprofen 400 to 800 mg 1 hour prior to the procedure. I request please unmute yourself. Yeah. So the duration of effect is 4 to 6 hours, and side effect is gastritis. Steps of manual vacuum aspiration. So first step is prepare the instrument, close the wall button, and create a vacuum by pushing that syringe. Then second is ensure pain control medication is given at the appropriate time, and ask the woman to empty her bladder. Then clean the cervix and vagina and lower part of abdomen with the antiseptic solution, betadine. Then administer paracervical block. We can use 1% lignocaine, and preferred sites for giving the paracervical block are 2, 4, 8, and 10. And if required, at the site of this Elise, we can give at 12 o'clock. Then dilate the cervix, insert the cannula. Then we have to withdraw the cannula 1 to 2 centimeter away from the fundus inside the uterine cavity, and then rotate the cannula in 10 to 12 o'clock position with a smooth, gentle motion, and then release the vacuum button on the aspirator. Signs that the uterus is empty. When we'll know that our process is complete, when the red or pink foam without the tissue passing through the cannula, there is a gritty sensation over the surface of the uterus, cervix gripping over the cannula, and uterus contacting around the cannula with increased uterine cramping. Then inspect the tissue, just strain the tissue which is in the vacuum machine with this, or in the syringe with the God's piece, and just inspect whether it is a blood clots or POCs, or there is any evidence of molar pregnancy. If patient is willing for any contraception such as IUCD or sterilization in the same sitting, we can go for that. Then instrument to have instrument to be soaked in chlorine solution, assist disinfection, and helps remove the tissue and body fluids. In postoperative care, monitor the patient for any complication and provide management as needed. She may leave the facility when she is stable and meets the criteria for the discharge. Ensure that woman has all necessary information and medication prior to leaving the facility. Document all the outcomes of the treatment, including any adverse effect, in the facility register and client register. Aftercare, management of abortion. In aftercare, it includes the management of abortion complication, such as incomplete abortion. If there is incomplete abortion or any infection or ongoing bleeding, excessive bleeding, or ongoing pregnancy, we have to manage this complication, treat this complication, or first diagnose the complication and then treat it. Provision of contraceptive information and offer the contraceptive counseling and method. assessment of any other sexual or reproductive health need that may require additional care. As such, no routine follow-up unless meso alone regime is used. This is a new recommendation. So to summarize, India has made the historic progress in improving the access to safe abortion. Not much has changed in technological update in last decades. As provider, it is up to us to ensure healthy, safety and quality, especially in the context of the amended law. Along with safety, we also need to focus on respectful abortion services. Every client that is in public sector or in private sector, it is an opportunity to us to inform, to educate, and to equip the woman with the proper information on contraception and counseling. So in India, abortion is legal. Let us make it safe and respectful. Thank you.
Thank you, Dr. Kanchan. I request any valuable inputs from the chairpersons, please.
The chairperson's mute. Okay, Varsha, as a MTP chairperson, you can again, you can be roped in for your expert comment.
The chairpersons are not available, kya?
I don't know.
Okay, okay. Kanchan, it was a wonderful talk. I mean, very much in detail, and you have explained each and everything very nicely. The only thing is OTC, over the counter, is not available nowadays, because we have also seen that if you write MISO to the patient, they are not going to get it, right? But the other thing which is troubling me nowadays is the Ayush people who keep on writing and prescribing these drugs. And then what happened is they don't keep any record in that, right? Once they don't keep the record, you never know where the patient has come, and she comes to you as a case of incomplete abortion. Or rather, if one of my colleague has written a medical MTP for the patient, she has entered her regular in the register, and then she comes to me that saying that, oh madam, माझं ते तिकडे माहिती होती आणि आता मी आता आली आहे, बघून घ्या आहे का, and it is incomplete, and then I do an evacuation for her. So I do not write it in the register. So our authorities fail to understand that once the patient is registered somewhere with a gynac, the entry is there. The second time entry shouldn't be there. Okay. These are few things which are very much confusing, and because of this confusion, people are troubling us. But anyways, I think the Foxy should again take a stand that just like RMP definitions are given, who can give the medical MTP, what are the weeks you can give the MTP. Likewise, it should be defined that any of the Ayush people don't come under RMPs. And Ayush people should not have the permission to give medical kits to the patients. That is it. That is one thing which we should fight for. We should take it in our stride. Right? So that is all. Baki the presentation was ekdam ultimate. Khub chhan bolis.
But Varsha, I feel Ayush people haven't been given, are not keeping the records as such.
They are not keeping the records, but they are giving the kits. They are giving the patient MTP.
Yes, but when such patients come from the Ayush people, we can put them in an MTP register, isn't it?
Okay.
But ma'am, Ayush
they come from the Ayush people, त्यांचा MTP मध्ये रेकॉर्ड घ्यायला हरकत काय मग तेव्हा?
आपल्याकडे येते तेव्हा ती इनकम्प्लीट होते ना अलका.
होतं, आपण इव्हॅक्युएशन मध्ये घेतो ना तिला, आणि मग
इव्हॅक्युएशन थोडी ना आपण MTP रजिस्टर मध्ये
यायला नाही पाहिजे, पण तरी ते ऑथॉरिटीज
आम्ही तर करतो MTP रजिस्टर मध्ये सगळे इव्हॅक्युएशन
इनकम्प्लीट. नाही तुम्हाला माहिती नाही
करायला नाही पाहिजे.
रीड दी MTP लॉ, इट इज नॉट दॅट. त्याचा एक RTI आहे आपल्याकडे which explains that incomplete, missed and inevitable abortions are not considered as
MTP form.
To keep them in other hospital record forms, जसं तुम्ही बाकी सर्जरीज ठेवता तशा ह्याच्यात ठेवायला हवं.
नाही, वन्स एकदा इन्स्पेक्टर आले होते, त्यांनीच आम्हाला सांगितलं की तुम्ही MTP.
तेच तर प्रॉब्लेम आहे ना. Why we are failing? Because the law is made, but how the law should be enacted to all the societies and the society members is not there. म्हणून आपल्याला हे सिव्हिल सर्जन लोक त्रास देतात, हे मेडिकल ऑफिसर्स सगळे त्रास देतात की नाही हे असं पाहिजे ते तसं पाहिजे. यू शुड बी एबल टू मेक देम सिट अँड पॉइंट आउट एट द बुक ऑफ द लॉ सेइंग दॅट याच्यामध्ये हे नाही दिलेलं आहे. I will share the RTI with everyone. Me Alkala Patwin. Alka will send it to everyone. So please don't be afraid. Don't be fearful. Don't panic. And because of these evacuations, आपला MTP चा number खूप वर जाऊन राहिलेला आहे. ज्या सेंटरला evacuations होतात आणि 50 MTPs होतात तर तिथे 100 MTPs झालेले दिसून राहिले. So MTP number shouldn't increase like that. Be very clear in your mind that evacuation is a procedure in which you are doing to save the person from bleeding and having other further complications. So incomplete, missed and inevitable are obstetric complications. They are not MTPs.
They are semi-emergency procedures. No?
Yes.
Varsha, totally agree with you, but we have to comply with
something, Dr. Alka.
Yes,
Dr.
yes.
Alka, can I add something, and Dr. Varsha also?
Yes,
Yeah,
yes,
I'm hearing this debate since last 5 minutes, but I would like to add that, you know, in areas around Pune, we are getting MTP kits somewhere from the shops. Patients are buying it and they are getting aborted at home.
Yes.
And then they come to us. That is the time also when we should, think about informing such cases to the government authorities.
Yes. So who is
the government
responsible for this?
themselves don't know that they themselves don't know. Yes.
Meenakshi, who is responsible for this? The Food and Drug Administration.
Correct.
These are the people who are responsible, and these are the people who should keep a watch on everything. It is not that we are sitting here, we are doing practice, we cannot keep a watch on all this. It is their responsibility, not us.
Yeah, same for Ayush people also. Same for Ayush.
Yes.
I mean, it is their responsibility to see who is buying the drugs and where the drugs go after manufacturing.
They fulfill their responsibility just watching over us.
Anyways, we are doing our job. We are maintaining everything strictly. Still, the people keep on harassing us.
Okay. The debate will end. Yes. Over to you, Manisha.
Yes, ma'am. We go over to the next session. That is WHO Saver Toolkit, Safe Abortion Values, Evidence and Rights Towards Respectful, Bias-Free Services by Dr. Sangeeta Balkote, ma'am. The esteemed chairpersons are Dr. Mangila Gisad, Dr. Shantala Bhole, and Dr. Rashmi Bhaisare. Dr. Sangeeta Balkote, ma'am, is a practicing gynec. She is in charge of Panchpauli Women's Hospital, NMC, Nagpur. I welcome you, ma'am, and hand over you the further proceedings.
Sure. Good evening, everybody. Am I audible?
Yes, ma'am.
First of all, I would like to thank Dr. Alka, ma'am, praise ma'am, who has given me opportunity to come on this platform and become a trainer. Thank you, ma'am. Should screen share.
Meanwhile, Mr. Shriman, are you there?
Yes, madam.
Yes, tell me, ma'am.
Yes, Shriman, we have to share a video in this presentation. It is not running in madam's presentation.
We have tried. I'll tell him.
Yeah.
Should I start?
Can I share the screen from my side, ma'am?
Till the time her video comes, let her share her screen. She will be comfortable sharing her screen.
Okay.
संगीता कसं करायचं तुला शेअर करायची की त्यांना करायची
सध्या जोपर्यंत मी अडत नाही तोपर्यंत शेअर
म्हणूनच आणि मग and whenever she is there her video comes you please do it.
Okay, ma'am.
Okay. Thank you.
I'll tell. Okay. Should I proceed?
Yes.
My topic is safe. My topic is safe abortion value, evidence, right, respect, and saver. This module aims to define respectable abortion care according to WHO standard, highlight how norms and stigma affects the services, provide WHO saver resources for RAC. Now, what is respectable abortion care? Adopted from respectful maternity care recommended by WHO, respectful abortion care refers to the care that maintains safety, dignity, confidentiality, ensures freedom from harm and mistreatment, and enables informed choice and continuous support during and after all types of abortion. In a simpler term, respectful care means you as a provider and as a patient treat and are treated with dignity, empathy, compassion, regardless of your race, ethnicity, gender, socioeconomic status, or reproductive history, pregnancies, miscarriages, or abortion. If you feel that something isn't right, speak up. As health professional, it is our duty to listen and support. Communication is the key. Now, uh, what are norms and stigma? What are norms and stigma? Norms are unwritten rules of behavior that are considered acceptable for group in the society. Norms and stigma are two different things. And now what is stigma? Stigma can be understood as a shared understanding that a person, a quality, or circumstances is somehow morally unacceptable. Can you please start? Now we will see a short video on norms and stigma.
Social norms are the unwritten rules of behavior that are considered acceptable in a group or society. Norms can change according to the environment, situation, and or culture in which they are found. People's behavior may also change accordingly. What are some examples of social norms? In times of COVID 19, there are new social norms that are considered COVID 19 appropriate behaviors like wearing a mask, maintaining social distance, and to wash or sanitize our hands regularly. An example of a social norm that we must follow at all times is to not use profanity in conversation, especially formal or official conversations or when talking to patients, clients. Now let's look at some examples of social norms around gender. Girls wear pink, boys wear blue. This is a gender stereotype. Girls and boys can choose to wear whatever color they like. Color has no gender. Men should be working, strong, and not show emotion. Women should be caring and nurturing and stay at home. Men should work and make money. Women should take care of housework and children. There is no need for women to own or inherit property. Now let's look at a few examples of norms around sexual and reproductive health. Just as norms around gender are smaller aspects of some broader social norms, norms around sexual and reproductive health also trickle down from certain norms around gender. According to the WHO, good sexual and reproductive health implies that people are able to have a satisfying and safe sex life and that they have the capability to reproduce and the freedom to decide if, when, and how often to do so. A woman should be married before getting pregnant and having unacceptable and immoral. Women are responsible for contraception. Now we see what is stigma. Stigma can be understood as a shared understanding that a person, a quality, or circumstance is somehow morally unacceptable. What are examples of sexual and reproductive health stigma? A shared understanding that sex before marriage is morally wrong and or socially unacceptable. A girl who uses a contraceptive method is promiscuous and will have problems when she decides to get pregnant. A married woman is more deserving of contraceptives than an unmarried woman. A girl who has had an abortion is committing a sin and brings shame to her community. Having an abortion has long term health effects, and the woman's health will never recover to her pre abortion state. Women who have had an abortion once would become habitual and avoid using contraception. It is important to understand that norms and stigma are different from laws and policies. For example, an unmarried girl seeking abortion is considered immoral due to stigma, whereas, as per law, Sex-selective abortion is illegal in India. In this exercise, we explore how social norms and stigma influence access of reproductive health and rights, how people experience SRH stigma, the impact social norms and stigma have on our actions personally and professionally.
So, norms, am I audible? Am I audible?
Yes, ma'am.
Huh. So, norms and stigma are two different things. Abortion is legal, but sex selective abortion is respect and abuse. It is category of disrespect and abuse. First is physical abuse, slapping, intimidating, screaming. Third is sexual abuse, abuse of power, and taking advantage. What is the right of every woman? Freedom from harm and ill treatment. Second is right to information, protection and
Sangeeta, your bandwidth is low.
informed consent and
Stop your
refusal.
video. Sangeeta, please stop your video and speak. Your bandwidth is very low.
Okay.
Stop your video. Yeah. Now you speak.
Now,
Yes, you're quite audible.
Fourth is stigma and discrimination, sever videos. Right of every woman is dignity and quality of the care. Fifth is failure to meet the professional standard of care. Sixth, poor rapport between women and providers, health system condition and constraint. What is the right of every woman? Right to timely health care and to highest attainable level of health, liberty, autonomy, self-determination, and freedom from coercion. There are domains of respectful abortion care. There are 12 domains of respectful abortion care. First, being free from harm and mistreatment, maintaining privacy and confidentiality, preserving women's dignity, respecting women's choices, engaging with effective communication, soft skills, providing information and seeking informed consent, ensuring continuous access to support, enhancing quality of physical environment and resources, providing equitable abortion care, availability of competent, motivated provider. 11th is provision of contraception, advice and commodity security. And 12th is continuity of care and counseling. Now, we move to the important slide, WHO training of safe abortion value, evidence, right, and saver toolkit. What does Saver, WHO Saver Kit says? It says no woman should die of abortion. WHO Seva is a module-based training for doctors, nurses, patient, place, health providers, program manager, and really anyone who is involved in respectful abortion care program. There are 4 modules for it: engage, inform, explore, equip. The Seva Kit is given in 4 forms. Now, let us see a short video prepared by WHO.
No woman should die due to an unsafe abortion. And when abortion is provided, it should be given in a legal and evidence-based manner with quality, safety, dignity, and respect. WHO has a toolkit on safe abortion values, evidence, and rights, or WHO Seva, which is a module-based training for doctors, nurses, health providers, program managers, and really anyone to assess our values, address our biases, and learn together to transform our attitudes towards respectful abortion care for anyone who needs it. During the COVID-19 pandemic, we adapted and converted the WHO Saver Toolkit into an innovative, gamified, hybrid version that you can do either in person, online, or as a combination with an expert trainer, or simply by playing one of the standalone games to learn from the comfort of your home. SAVOR has 4 modules: Engage, Inform, Explore, and Equip. In the Engage module, participants review recent media stories from the country about gender, unintended pregnancy, the realities of safe and unsafe abortion, and juxtapose these with the global standard definitions. In the Inform module, participants share and discuss background information on SRHR, on safety of legal abortion, contraceptive prevalence, abortion incidence and safety, abortion law and safety, and achieving reproductive rights in the global and regional or local context. In the Explore module, participants will play various games and watch videos relating to gender, safe abortion, preventing unwanted pregnancy, explore social norms and values, and consider how these may towards respectful abortion care for
went wrong.
should die due to an unsafe abortion. And when abortion is provided, it should be given in a legal and evidence-based manner with quality, safety, dignity, and respect. WHO has a toolkit on safe abortion values, evidence, and rights, or WHO SAVOR, which is a module-based training for doctors, nurses, health providers, program managers, and really anyone to assess our values, address our biases, and learn together to transform our attitudes towards respectful abortion care for anyone who needs it. During the COVID-19 pandemic, we adapted and converted the WHO SAVOR toolkit into an innovative, gamified, hybrid version that you can do either in person, online, or as a combination with an expert trainer, or simply by playing one of the standalone games to learn from the comfort of your home. SAVOR has 4 modules: Engage, Inform, Explore, and Equip. In the Engage module, participants review recent media stories from the country about gender, unintended pregnancy, the realities of safe and unsafe abortion, and juxtapose these with the global standard definitions. In the Inform module, participants share and discuss background information on SRHR, on safety of legal abortion, contraceptive prevalence, abortion incidence and safety, abortion law and safety, and achieving reproductive rights in the global and regional or local context. In the Explore module, participants will play various games and watch videos relating to gender, safe abortion, preventing unwanted pregnancy, explore social norms and values, and consider how these may be rooted in stigmatizing attitudes or contribute to stigma from a personal perspective. The Equip module is to promote knowledge of, interest in, and further use of WHO guidelines and tools, with a focus on guidelines and tools relevant to contraception, abortion, and post-abortion care, towards the many steps needed for achieving the Sustainable Development Goals, also known as SDGs, building resilient health systems for universal health coverage, or UHC, leaving no one behind. We must remember quality and dignity of care matter as much as saving lives. SAVOR is our small step towards SDGs, starting with ensuring safe abortion is provided with values, evidence, and rights or respect. No woman
Now,
should die
next-
due to an unsafe abortion.
Hello. Now, as a RAC, am I audible? Now, as a RAC provider, how our language should be, it is given in this slide. Can you please play Guide to Avoid Stigmatizing Language?
How to talk about abortion, a guide to right-based messaging. Abort a child is medically inaccurate as the fetus is not yet a child. Terminate a pregnancy is commonly used. However, some people prefer to avoid this as terminate may have negative connotations for some people. For example, terminator or assassinate. In some contexts, the word abortion can be perceived as negative. In these situations, it may be helpful to avoid the word completely and use termination of pregnancy instead. It is important to be legally accurate, and in India, abortion is legally permitted to the full extent of the law. However, in many parts of the country, the barriers to access may be so great that abortion is considered by many to be illegal due to conflations with other laws. Make sure that you share accurate information about the legal situation and make the circumstances under which abortions are legal clear. See the WHO Global Abortion Policies database for information on the legal status of abortion across the world. Let us look at some stigmatizing words and how to avoid them. Abortionist is a term used by those opposed to abortion. Healthcare provider is usually a more accurate term to use than abortion provider, as most of those providing abortion care also provide other health services. In India, they are also called RMPs or Registered Medical Practitioners. The preferred terms are medically accurate as the embryo or fetus is not a baby. When referring to the tissue examined following a surgical abortion, an appropriate term is products of conception. However, this term is only useful for materials focused on medical details of abortion, as it is not commonly used or understood outside of medical or scientific contexts. Conscientious or moral objector implies that those who do provide abortions are not conscientious individuals, which is incorrect. Refusal to services must be well founded. For example, sex selective abortion in India is illegal. This tends to suggest an act of wrongdoing, placing unwarranted blame on the woman and frames parenthood as punishment. The right to abortion should never be linked to how or why a woman becomes pregnant. Abortion is a woman's right and choice. Consider the classification of pregnancies into the categories unintended, unplanned, unwanted, or mistimed. The classification relies on a framework that assumes that pregnancy is, should be, or even can be a conscious decision. The complexity and possible ambivalence of pregnancy intention, as well as the dynamic nature of childbearing decisions before, during, and even after pregnancy, are not accommodated in these classifications. The suffix "side" denotes killing, which is not appropriate when describing abortion. When referring to sex-selective abortion, it is more accurate to describe the practice in terms of choosing to end the pregnancy based on the predicted sex of the fetus. Make it clear that abortion is about making an informed decision, and avoid the implication that ending a pregnancy is done without careful thought or consideration. The term keep implies a positive outcome, which may not accurately reflect the situation. In addition, it is medically inaccurate to describe the pregnancy as a baby or child. It is more accurate to describe the situation as a pregnant woman choosing to continue with the pregnancy. Late term could refer to any time in the second or third trimester. Instead, if necessary, use terms that indicate the specific trimester or gestation. Use of late may also imply that a woman is late and thus irresponsible in seeking an abortion. For example, there is no gestation limit for birth defects and associated abortions in India as per the recent MTP amendment of 2021. Use of mother, father, parent during a pregnancy is value-laden and assigns roles that the man or woman may not accept. It also implies that the fetus is a child, which is not accurate. Also, under the MTP Amendment 2021, in India, any woman and her partner, married or unmarried, can seek abortion. Abortion is not contraception. Contraception is to prevent a pregnancy, whereas abortion is to terminate a pregnancy. People often seek abortion due to the occurrence of an unintended pregnancy or for health reasons, and there will always be a need for safe and legal abortion. All reproductive choices and care should be available and supported. People should be supported to prevent unintended pregnancies with access to contraception and accurate information. Pro-life implies that those who support legal abortion access are anti-life, which is inaccurate. Instead, use alternative terms to make it clear that you are referring to individuals opposed to anyone having an abortion. Where possible, our language should reflect the fact that we are service providers with a focus on providing rights-based quality healthcare and support. In order to dispel myths about organizations that provide abortion care, it might be useful to avoid business related language. Multiple and repeat can have negative connotations, such as repeat offenders. Multiple and repeat also imply that each abortion experience for a woman is the same, whereas each abortion is surrounded by a unique set of circumstances. If safe, what is wrong with having multiple abortions? Because abortions happen under a wide range of cultural, legal, and medical circumstances, it is important to be careful about the terms that you use to avoid mixing up terms and creating confusion. Here are a few phrases to be aware of. Illegal abortions are those that do not comply with a country's legal framework but may be safe if performed by a trained provider or when a person has access to high quality medication, information, and support to safely undergo a medical abortion in a safe and licensed place. Remember, abortion is considered safe as per WHO guidelines when the 3 P's provider, place, and process are safe, trained, and certified. Unsafe abortions are performed by providers who are not registered or trained, or in situations where people are unable to safely undergo a medical abortion due to lack of access to high quality medication, information, or support. It is possible to have an unsafe legal abortion. Unwanted pregnancy is a pregnancy that a person decides they do not desire. Unplanned or unintended pregnancies refer to pregnancies that occur when a person is not trying to get pregnant. An unplanned or unintended pregnancy may be either a wanted or unwanted pregnancy. In India, abortion is legal, but sex selective abortion is illegal. Provider and place need to be safe, trained, and certified.
Momentum. Next. Momentum has created, law has changed. Momentum has created, law has changed. Dissemination Needs Association of Obs-Gynae provider support. Foxy is the largest provider base for abortion care. Online training is possible due to COVID. Respectful abortion care can reach all providers. MMA uptake has increased. Early, safe, and ensures no PCPND conflation. Patient safety, respect, and quality matters more than ever, and we all have to play the role. Law has been changed on 25th March to 2021, and rules have been implemented from 24th September 2021. Now it's time to strengthen the implementation. This is the important slide. Image 1 shows important changes for the provider opinion. Every patient is an opportunity for respect, and as a provider is on us to educate and also reduce sex selective abortion. One provider, one RMP can give up to 20 weeks of abortion, and his responsibility is more. He has to do the counseling, contraception advice, referral, and compassionate care. Secondly, we have expanded eligibility, especially for young people, survivors, unmarried, everyone, survivors, unmarried, minors, mentally retarded, where there is change in marital status, widows, mentally ill patient, and fetal anomaly patients. Everyone need unblast care, and we need to overcome our own blashes. 20 to 24 weeks of our gestational age from 20 to 24 weeks for special cases needs sensitivity and judgment-free and timely services. Birth defects, of course, our medical board comes in action. Now, third image gives us information of prioritizes confidentiality and safety. Respect begets respect. As providers, we need to be mindful for socio-cultural aspects. Name and other particulars of any woman seeking abortion is to be kept confidential except to the person authorized in any law for the time being in the force. The ground of failure of contraception has been extended to woman and her partner. Respect, quality, and dignity at all type of abortion. Next slide.
Please mute yourself. Hello.
Hello.
Who is talking?
Next slide. Next slide.
Please
Mr.
mute everyone. Srimali.
Next slide. From 1970 up to 2000, it was from 1970 up to 2000 was a period of unsafe abortions. From 2000 up to 2020, it was a period of safe abortions. And now 2020 is respectful abortion. Now we come to recap questions. According to WHO, next slide please, Bashir. According to WHO, restricting access reduces the number of unsafe abortion. Is it true or false? Answer is false, because when we consider, according to WHO, when is abortion considered safe? There are two criteria given by WHO by appropriate method. One is appropriate method and by trained person. If both the criteria are fulfilled, then it is a safe abortion. And if any one of the criteria is met, then it is less safe. And if both criteria are not met, then it is an unsafe abortion. Now we come to the second question. Next slide, please. Bashir. The MTP Amendment 2021 requires a minor less than 18 years to obtain written consent from parent guardians before she can undergo a termination of pregnancy. Is it true or false? The answer is false. We as a RAC provider, services provider, should not deny. Of course, POXO comes in action. POXO reporting is needed. We need to provide bias-based free services without judgment. Now, next slide. 30 years old woman, Bashir, 30 years old woman, recently widowed, wants to get an abortion at 22 weeks. As a provider, it is your responsibility to tell her to continue this pregnancy, yes or no? The answer is no. Again, same. Up to 20 weeks, 1 RMP, 20 to 24 weeks, 2 registered medical practitioner, and beyond 24 with birth defects or something, medical board come in action. To sum up, RAC, respectable abortion care and saver tool, ultimately aims, according to WHO, good sexual health and reproductive health implies that people are able to have a satisfying and safe sex life, and that they have the capacity to reproduce and the freedom to decide to when and how often to do so. Thank you.
Very nice. Yes, chairpersons, please. Manisha.
Yeah, good evening. I think it was an excellent presentation by Dr. Palkote, and we actually got to learn a lot of new terminologies that we can actually use. Sometimes unconsciously we might be using different terms, but I think we need to also, change according to the times. Very elucid and very informative presentation. Thank you, ma'am.
this was a very nice presentation. Congratulations, Sangeeta madam. And once again, congratulations to Alka ma'am for providing us with this beautiful program. And really, it is very important nowadays. And we should, everyone should know that what are the recent rules and amendments, actually. So thank you very much, ma'am, for making me the part of this project. Thank you.
Yes. Thank you, everyone.
Thank you, Dr. Thank you, Dr. Sangeeta, and thank you, respected chairpersons. We go over to the last session, but the equally important session of the day, the pre and post-abortion family planning, counseling, leveraging technology for referrals, and online consultations by Dr. Vaishali Varadkar ma'am. The chairpersons for this session are Dr. Shama Kedar, Dr. Amok Chimote, and Dr. Aarti Vanzari ma'am. Dr. Vaishali ma'am has already been introduced. Ma'am, please, can you go over to your topic?
Just a minute, okay. I'll take a few minutes, okay?
Yes, ma'am, yes.
काय झालं?
What happened?
Can I share the screen?
Yes. Who is not able to share? Manisha?
Yes, ma'am.
Yeah.
Yes, ma'am.
Yes, whose turn it is? Whose lecture is balanced?
Dr. Vaishali Varadkar, ma'am. Pre and post abortion family planning counseling.
So what happened? Vaishali is not there? Just
a minute, ma'am.
Yeah, just a minute. I'm just sharing the screen.
Okay, Vaishali. लेट होते हैं ना म्हणून विचार.
हो, 1 minute मला.
कोणतं आहे तुझं?
It's not
ओपन झालं. आता याला हे कर.
काय करू?
हे
स्क्रीन शेअर करावं लागेल आता. स्क्रीन शेअर नाही जाते.
वैशाली या एंडनी चालून देतो ना तुला?
बस झालं.
आता झालं. मॉड्यूल आहे ना? तू तुझ्या ऑन तर कर.
1 सेकंड. व्हिडिओ ऑन करते.
तुझं दिसत.
झालं?
How ma'am, it's visible.
Yeah.
Yeah, make it slideshow. स्लाइड शो होतोय का मॅडम?
नाही तो होत नाही स्लाइड शो.
1 मिनिट.
मग यांना करू दे ना वैशाली. यांना करू दे. झाला ना स्लाइड शो? व्हाय इट इज नॉट देयर? इट इज स्लाइड शो.
फाइन मैम.
हां, स्लाइड शोच आहे.
ओके. हां, स्लाइड शो आहे.
Yeah. As rightly said by Manisha, we are again dealing with an important topic which is part of respectful abortion care. So every woman who seeks comprehensive abortion care services must be offered counseling. And counseling is an important part of comprehensive abortion care and is equally important as performing the procedure correctly. So let's have a look at what is counseling. WHO has defined counseling as a structure. It is a structured interaction in which a person voluntarily receives emotional support and guidance from a trained person in an environment that is conducive to open sharing of thoughts, feelings, and perceptions. So every woman who seeks comprehensive abortion care must be offered counseling, that is before the procedure, during the procedure as well as after the procedure. And healthcare providers, nursing staff, paramedical staff, and counselors, if available, may be appropriately trained to offer abortion-related counseling services. The process of decision making may be difficult for that particular woman, and she may need help. So she will have then, and whenever needed, we have to include the spouse. So she has to decide whether to use a temporary or a permanent method of contraception after the procedure. So it is up to her. What we are going to do is help. What is it? The important points in counseling: help a woman decide about termination of pregnancy, whether she has to terminate or continue. Counseling will help her to choose the method of termination. It will ensure that delivery of complete information about the procedure she has received. Then it will also help the woman to adopt a specific contraceptive method. The salient features of this counseling procedure, we ensure that we should keep in mind that privacy and confidentiality is maintained. Then we should be non-judgmental and be sensitive. And we should establish a rapport with the women to gain her confidence, as abortion itself is a very sensitive issue. And then she may be reluctant to discuss it. So building a rapport helps in finding out whether there have been any attempts to terminate this pregnancy in the past. And it is very important in predicting, for us to predict some problems she may have, or she may land up in some infection, and so that we can manage that. Then simple use of simple language, as we had heard in the previous lecture, and it allows the woman to clarify her doubts. So if she has made up her mind for termination of pregnancy, then she should be she should be able to assess what procedure she is going to undergo. These are very important points of counseling. Then we should make it clear right away that her fertility is not, especially if she wishes to have a child later on in her reproductive life, then we should make her take her into confidence that the return of fertility may be immediately it may not hamper her fertility. Then this is the right time to accept certain methods of contraception. Then she should keep a minimum gap of 6 months before planning a next pregnancy. Then it will not hamper her future pregnancy outcomes. And by ensuring that she accepts one of the methods of contraception, then we can reduce the morbidity and mortality related to unsafe abortions. Then when should we start counseling? First, it should start right away with her first visit or first consultation. We should accept in certain situations it may be delayed, maybe her state of mind is not she is not in a comfortable state of mind, she wishes to come again, then we can defer it, but otherwise it should start in the first visit itself. Then what to counsel? Again, I'm repeating, the return of fertility is immediate, especially after a first trimester abortion. It may be within 10 days, and after a second trimester abortion, it may take a month or so. And we should help her with the choices, the method specific counseling about regarding the contraceptive methods which she can use, and the wherever applicable some high risk factor is there, we should be very clear in counseling her. And if she is not if she is not willing to accept any of the methods of contraception, we should we are stating every time that she should not be refused MTP if she is denying any contraceptive method. If she is denying either she is not ready to accept any of the contraceptive method, but MTP should not be denied, because if we are refusing MTP, she may go to any other untrained person, and then there will be chances of unsafe abortions. So every time we can even try to counsel her after the procedure that she should accept some of the method of contraception. Then assessing the suitability for post-abortion contraception is important. Before that, we should, before giving her any of the method of contraception, we should ensure that the abortion is complete. There is no existing infection. There is no injury to her genital organs. And also chances, if she's coming after maybe 15 days, so chances of further pregnancy are ruled out. Then post-abortion counseling plays a critical, it is also an, after the abortion, the counseling is this is also an integral part of the post-procedure care. And it is as important as pre-abortion counseling, because it ensures that the woman has understood the precautions and care needed during the post-abortion period. It gives an opportunity to counsel for contraception in case she has not accepted it previously. It also reinforces the need for continuing the use of contraceptive methods chosen. Then the post-procedure counseling procedure should be, the 3 words should be kept in mind, that continue to ensure privacy and confidentiality at each and every level. We should reassure her in case of any problems. She should feel that confidence. Then repeat the information about post-procedure care and danger signs to her on every of her visit. What we should, during the counseling, if she has already opted any of the methods of contraception, we should appreciate her. We should tell her about the immediate care required. Then if she has opted for hormonal pills, then what ongoing care she would require every time. The follow-up protocol is to be informed to her when she should come for follow-up, and at what spacing should the follow-up be. If she has not decided, if she is still undecided, then we should allay her anxiety. We should tell her the importance of adopting or choosing any of the methods of contraception. Then extending the period of adoption, maybe she will come later on. Then couple counseling is also important, that next, if she has not decided, we can ask her to get her husband or partner in the next visit. We should also tell her about the emergency contraceptive pills to avoid further abortions. Then coming to the methods, which different methods we can have, the different timing of contraception. When she has opted for barrier methods, the timing of she can opt for condoms. Her partner, as soon as the sexual activity after the first trimester abortion, it is because her fertility is resumed immediately. So whenever she resumes sexual activity, immediately she should use one of the barrier methods. Then after the second trimester abortion, as soon as again it is same, as soon as she resumes sexual activity. The main features of using barrier contraceptiva, there are no hormonal side effects. These are easily available over the counter. Then they can be used without consulting a healthcare provider. They help in preventing the STDs, including HIV, enables the men to take the responsibility along with the woman. In case she has opted for intrauterine contraceptive device like IUCD 380A or IUCD 375, then after a first trimester termination, we can insert it immediately or within 12 days after confirmation of a complete abortion, when the surgical methods were used. And when the medical methods of abortion was used for a first trimester termination, they can be inserted around day 15 of the process, provided we have ensured that the abortion is complete and there is no infection, and the other indications for IUCD have been ruled out. In case of second trimester abortion, it can be inserted immediately or up to 12 days after the procedure is complete and the contraindications have been ruled out. The important salient features of intrauterine devices are they are highly effective. One-time motivation is only required. They provide long-term contraceptive for 3 to 5 years or 10 years, they can be provided, but they have to be inserted by trained doctors. A&M and nurses can have it after first trimester surgical abortion, but personally, I would not recommend it, but trained doctors are okay. Then postpartum IUCD, trained doctors after second trimester abortions also. So the important point is there is no interference with sex. There is immediate return to infertility after the IUCD is removed. Then in case of hormonal contraception, especially the combined oral contraceptive pills, again, they can be started immediately after a first trimester abortion or within 7 days after a surgical method. But in cases of medical methods of abortion, they can be started on day 3 with the after the dose of misoprostol or within 15 days of after confirming the complete abortion. During the after a second trimester abortion, also they can be started immediately or up to 7 days after the abortion. Then the advantages being they regulate the menstrual cycle, can be provided by healthcare workers also after the woman has been screened by trained provider. There is no interference with sex. Often they offer protection against ectopic pregnancy, endometrial and ovarian carcinoma, and other benign diseases. But they are not suitable for women who are breastfeeding within 6 months of their delivery. So then coming on to the long-term injectable contraceptives like medroxyprogesterone acetate, it can also be started immediately or within up to 7 days after a surgical evacuation. And in case of medical methods of abortion, it can be started on day 3 with the dose of misoprostol. So, and in second trimester abortions, it can be started immediately or up to 7 days after abortion. Again, they are highly effective. Then confidentiality and privacy is maintained. They can be provided by doctors, healthcare provider, and ANMs and nurses after first evaluation. Further injections can be given by ANMs and nurses. There is no interference with sex, no effect on the quality and quantity of breast milk, there being progesterone, the content being progesterone, no estrogenic side effect. They again offer protection against ectopics and the carcinoma. Then the permanent methods, they can be concurrently used with the abortion procedures. Like if we are talking about tubal ligation, then it can be performed after an abortion in the absence of any infection or severe blood loss, or up to 7 days after a mini lap in case of first trimester, of course. In cases of both mini lap and laparoscopic sterilization can be performed, and with medical methods of abortion, it can be done only after the first menstrual cycle, because it being the permanent method. Then after a second trimester abortion, mini lap can be performed concurrently or up to 7 days after an abortion, but we should ensure that there is no infection or severe blood loss. But laparoscopic sterilization should be avoided after a second trimester abortion. Then it is a permanent method of contraception which is highly effective immediately. There is no interference with sex, no effect on the breastfeeding, no long-term side effects. It offers protections against ovarian cancer. Then talking about vasectomy, which is performed on the males, so it is independent of the timing and procedure of the abortion. Only thing is that the male partner is also involved in the reproductive health of the women. It is very effective, a permanent method. It does not interfere with sex. Only thing is that 3 months abstinence should be advised, so that there is no in between, there is no pregnancy. Then as I already told you, the contraceptive methods with medical methods of abortion, after in case of pills, injections and centroman, it should be started with the date after the first pill, that is with misoprostol, day 3. But IUCD, or combined pills can be started till 15 days once ensuring that the abortions are complete, and even tubectomy can be done after 15 days when we are sure that the abortion is complete. Talking about, again, this is in short about the surgical contraceptive advice after a surgical aspiration. Here also they can be immediately given or within 7 days. The achieving universal access to sexual and reproductive health services is fundamental to empowering of women. So these days, as we are all going through the pandemic and not meeting and almost sometimes meeting on virtual platform, so teleconsultation and the latest technologies should be used. They can be used to make significant changes to our advantage as well as to the advantage of our patients. So all these teleconsultations, these telecounseling, teleguidance, these are all recent terms. Telelinkage, telereference, they may have their pros and cons, but they are the need of the hour. Then even again, using the recent technology for information, education and communication, all these sites and WHO and Ministry of Health and Family Welfare site, all these websites can be of help for advising the patients to have a look at them in case they have some issues. Then the pros and cons of teleconsultation, as we can say it as SWOT, the strengths of teleconsultation being in COVID era, it is to our advantage as well as to the patient's advantage. We are approachable throughout the process, so a confidence is built. Then we can spread awareness through virtual platform. The drawback being there is no face-to-face contact. We can demonstration is some restrictions are there for demonstration, but it gives an opportunity that the privacy and comfort is maintained. It is cost saving. The number of visits are cut down. But again, how much it helps, sometimes the opportunities can be missed or a diagnosis can be missed. The components of comprehensive abortion care can be under these heads. That first we should assess the confirm the diagnosis, look at the contraceptive need, it should be assessed. Then counseling, it can be face to face, a video conference or a Zoom platform can be used. Then follow up, maybe one visit or 3 visits as in medical methods of contraception are needed. So the take home message will be realize the need of post abortion counseling, then bring the couple on board and strive for 100% coverage, capitalize on the basket of available options, applicability in the post-abortion period, use the technology to our advantage, and adolescent reproductive health needs both online and offline. Thank you so much.
Yes,
Thank you,
Chairperson.
ma'am. Thank you, ma'am. Any valuable inputs from the chairpersons, please?
Hello.
Yes, Aarti.
Yes, thank you, ma'am. Very wonderful lecture, Dr. Vaishali. First of all, I congratulate you. And I think that counseling is very important in the pre and post-abortion cases, especially about the procedure, about the pros and cons, and especially the patient is worried about future pregnancy. So she need to be counseled nicely about the pros and cons and whether she would be pregnant or not. Again, in counseling about contraception is very important, especially about IUCD. There are many misconceptions that as a gynecologist, we should offer correct information about the pros and cons of the IUCDs. And vasectomy should also be encouraged, I think so. Thank you so much.
Yes, any other chairperson over there? So teleconsultation is a new thing on the horizon for this MTP. And the basic things we are like like Aarti has pointed out very well, that patients, they don't understand the need for contraception, and we many times see patient la kalat padne ki त्यांना contraception घ्यायला पाहिजे. After post MTP, it is our duty to tell the patients that after if she doesn't want pregnancy, she should use some type of contraception. Be it you should explain them all the modalities which are available for contraception. While counseling the patient for MTP, you should be open enough to give them the options like medical termination of pregnancy as well as the surgical one, and explain them every pros and cons of both the methods. If you explain them properly, counsel them in a giving by some time, then patients, it will be considered as a respectful maternity, a respectful abortion care, and post-abortion care is equally important, as very well stressed by our speakers. And I feel this is all about MTP. And we should be genuine in our opinion. We should maintain the proper record, confidentiality of the patient, maintain the record, and send your record every monthly. That is very important. That's all. So in a proper format, that too. Ashish, are you there? Ashish sir, are you there?
Yes, I am here.
Yeah. So it's now your turn.
A very wonderful and the most elaborative this CME on this MTP, and nowadays at present it is the very hot topic. As you know, there is the media trial of one of the controversial cases of MTP. Then second thing, the new law of 2021 is now already this published in the Gazette, but yet not in the implementation, because the rules and regulations are not framed by the individual state government. And in the next near future, it will get implemented. And on this background, and the third important thing, that at present there is the Dhadak Mohim by this MTP squad of Nagpur Municipal Corporation, which is in charge of this MTP care of this city. And on this background, this CME, the very high profile, very aimful, this project of our Foxy, and very well elaborated by our own society members. Thank you, speakers, Kanchan, Sangeeta, Vaishali, everyone. All Chow, Manish Chow, the wonderful effort by all our speakers, not but the least viewers who have joined and enlightened about this recent knowledge of the MTP and the MTP Act. Thank you very much from the bottom of my heart.
Thank you, all the chairpersons.
Thank you, Alka ma'am, Ashish sir, for this opportunity. Please go through the post test and give your valuable feedbacks at the close of this training before you leave the meeting.
Yes. You announced the message I posted that dear delegates, this project RAC is unique in content as well as the technique. You are here only after you have given this pre-test and got registered. Similarly, at the end of the session, all the delegates, they need to click continue in the pop-up. Don't click exit. Submit the post test and feedback form, and then you are eligible for RAC training certificate at the end of complete session only. So please, everybody do the same, and then leave the platform. Thank you so much.
Thank you, ma'am.
Thank you, ma'am.